Hey guys, this is still lesson 1 in CT 4071. We are going to start talking about imaging the non-contrast CT head brain. In today's lessons, we're going to be discussing positioning, imaging, and anatomy of the non-contrast CT head. While I have no specific data to back this up, I do believe that the CT head is probably the most ordered scan that the CT technologists are going to perform. Like the chest is to radiography, the CT head is to computed tomography. So it's a very important, valuable tool to the physicians to evaluate many symptoms ranging from headaches to dizziness to acute stroke patients. With older generation single slice scanners, CT heads could take as long as 5 minutes to scan, but today the scan time is measured in seconds. So it is the most ordered scan because it's become a fast, effective means of ruling out life-threatening medical emergencies. So you'll notice on this slide there is a scout or a topogram or a localizer that we talked about in the localizer lecture. And as I said, typically a lateral scout is all that's required for a CT head. You can see the scan lines that are located over the scout image, and these are the lines that are prescribed for this scan. The lines start at the orbitomeatal line and proceed through the brain to the vertex of the skull. But this is the old method of a beginning point for the CT head. The new standard is to situate the scan lines parallel to the supraorbitomeatal line in order to spare the lenses of the eyes from receiving unnecessary radiation dose. You may see both on the CT registry, so just know that the difference between the two and which one is the standard protocol now. So in starting scan lines at the supraorbitomeatal line, the scan lines will be angled to follow the base of the skull. It's preferred to have as little angle on the gantry as possible. In order to do this, most facilities have a wedge that's placed underneath the patient's head to tilt the chin down toward the chest, which places the base of the skull in a more perpendicular position. Most of the time, you'll have to ask the patient to duck their chin toward their chest and keep it there for the duration of the scan. The scanners are equipped with laser or light alignment lines. Utilize those lines to ensure that the patient's not rotated from side to side or that their head is not tilted to one side. It's more of an issue to be tilted to one side because that means that you're not getting a representative slice through parallel through the brain. When it's tilted, you're going to be off a little. So if their head is rotated to one side, at least your slice thickness or your slice is going to be accurate. So it's very important that they're not tilted, that their head is not tilted off its axis to one side or the other. And those alignment lights can help you make sure that that's not happening. On older or more kyphotic patients, sometimes extremely difficult to get the base of the skull perpendicular. In that case, the technologist has a couple of aids. Number one, you can place a large wedge underneath the patient's buttocks, which kind of lowers the head further into the head cradle. Number two, you can use a steeper angle of the gantry, or number three, you use a combination of both, which is the most common remedy. So the scan lines on the localizer are parallel to the supraorbitomeatal line and begin at the skull base or the posterior fossa and extend through the vertex of the skull. The petrous ridges cause artifacts in the image due to beam hardening, which is a phenomenon that we're going to discuss in physics. Thinner slices are needed through the posterior fossa to overcome this, and so 5mm slices are usually sufficient. Most locations will scan 5mm slices through the remaining portion of the brain as well. older single slice machines had to be set up with two sets of scans, one through the petrous ridges with thinner slices, and then one through the remaining portion of the brain with thicker slices, usually set up as 5 millimeter and then 10. But pay attention to the slight thickness at different facilities you visit during clinical rotations to see the variations and if there are any variations. You'll also have to use a small display field of view, or DFOV, and a head algorithm scan field, I'm sorry, not algorithm, but head scan field of view, or SFOV. We'll discuss those later in the physics class as well. But some machines have names for the SFOV selections, such as head, small, large, pediatric, etc. And most of these are going to be built into the protocols that are set up in the machines. But the display field of view is controlled by the technologist by opening and closing the scan lines to include the necessary anatomy while you're setting up the scan for the scan parameters on the scout image. On this slide are the indications for CT head. On the without IV contrast side on the left of the table, the indications that are listed are trauma, which can be hemorrhage or hematomas. Remember this, IV contrast may hide subtle signs of hemorrhage because the blood and the IV contrast are hyperdense compared to the brain tissue. So if IV contrast is floating around in the brain, it can mask a bleeding vessel. And for this reason, a CT head is never performed with IV contrast only. There will always be a non-contrast head performed first, unless, of course, the patient was scanned without contrast earlier that day. The second indication is acute stroke. We'll discuss acute stroke in detail in the pathology and pharmacology class, but very common to scan folks for an acute stroke. Hydrocephalus, which is excess CSF in the ventricles, can cause them to swell and affect the patient dramatically. Primary tumors, these can be meningiomas, schwannomas, and gliomas, or astrocytomas, sometimes called gliomas as well. Metastatic lesions, these are commonly from lung, breast, renal, or GI cancer. Bony abnormalities and injury, abscess, and 3D surface models, which these don't require contrast, so you can build those without IV contrast. And on the with contrast side, we have AV malformations, or arteriovenous malformations, known as AVMs. The IV contrast delay for demonstrating venous blood flow is approximately 90 seconds. IV contrast amounts vary from location to location, but generally 75 milliliters at 2 milliliters a second is adequate for that purpose. For CTA brains, the contrast must be injected at a much faster rate of about 4 milliliters per second. And this is going to be covered in the CTA portion of this course. CT images are often viewed with filters or algorithms or kernels. Without going into too much detail, we need to explain what an algorithm is, because I'll be telling you which body part, which algorithm goes with which body part as we go along. Algorithms use a formula called the Fourier transform theory to reduce statistical noise and create an image that's pleasing to the eye. Filter options are also called kernels. They can be applied to smooth an image or accentuate differences between neighboring pixels. In the case of the CT head, an edge enhancement filter is used for bony structures, and a soft tissue filter which is used to smooth out the soft tissues of the brain, is used for white and gray matter. So on the left you have the soft tissue filter, where the bone is just very white and there's no detail, but the tissue is nice. And on the right you have the bone window or bone algorithm, which gives you great bone detail, but you can't see the soft tissue. Usually these both of these algorithms, bone algorithm and a soft tissue, are turned into the radiologist. Another method of adjusting the image to be pleasing to the eye is that of adjusting the window level and the window width. These will be explained in greater detail in physics, but so that you have an idea when you start the clinical rotations, I'll give you a brief definition of the two. The window width and the window level refer to Hounsfield units, which quantify the degree that a structure attenuates an X-ray beam. Dr. Hounsfield developed a numbering system where it assigned distilled water the value of 0. He then assigned the number 1,000 to dense bone and negative 1,000 to air. All body tissue include fluid, air contained within the body, and the tissue itself fall within this range of numbers relating to their attenuation characteristics. So pertaining to images on the scanner, the window width controls the contrast and the window level controls the brightness that our eyes perceive on the monitor as we're looking at the images. The table on this slide shows us that when viewing the gray or the white matter of the brain, a window level of 35 and a window width of 100 is optimal, whereas if the technologist wants to evaluate the bone and evaluate the bone, a window level of 400 and a window width of 3,000 is optimal, and so on. The window width and window level are subjective and are not set in stone, but most protocols already have these options built into them as well. In the Romans textbook at the end of the chapters on imaging procedures of each body region, the authors included a table of general protocols for that particular body region. You may find these helpful, especially after you graduate, if you're tasked with developing protocols for some rural hospital who's never had a scanner before, and you get to develop the thing. This book might be helpful for you. So what we're going to do now is go through that table. Just take a glance at it with me. In Romans, find it in Romans, and then we'll go over it. This edition is page 253. It could change later. So the first section gives us examples of clinical indications of the exam. We talked about these. They include intracranial hemorrhage, hydrocephalus, trauma, etc. AP and lateral scouts are recommended in this protocol, but usually only a lateral scout is needed. The scan type is axial opposed to helical. And the reason is that multi-slice scanners do not allow angling of the gantry during helical acquisition. So most routine head scans are scanned axial. Helical is reserved for scanning a patient rapidly if there's an issue of motion. So the scan plane is transverse, and as we said, the start location is just below the skull base to just above the vertex of the skull. 75 to 100 milliliters of contrast at 1 to 2 milliliters per second is routinely used, and a scan delay of 5 minutes is long, but most facilities begin scanning after 1 to 2 minutes. Pay attention to the scan delay at your clinical sites. Compare it to the others just to give yourself an idea of what's going on. A reference angle. We want to use as little angle on the gantry as possible, but angle the gantry parallel to the supraorbitomeatal line in the base of the skull. You want to be able, like I said, to have the patient position themselves so that the base of the skull is perpendicular. You don't really have to use an angle. That's the ideal situation, but that's not always the case. The DFOV will be small, and the scan field of view will be head. Standard or soft tissue algorithms used, and as you can see, the window width and the window level settings are subjective and vary from department to department. But these listed in this protocol are within the range and are acceptable. The author lists protocols for 16 detector scanners and 64 detector scanners. So you can look through those and familiarize yourself with them. Because we'll be studying detector configurations and all that and how it plays into obtaining our images in the physics class. Reconstructions, or what we refer to as bone windows, consist of an algorithm of bone and a window width setting of around 4,000 and a window level of about 400. So we'll kind of look at these protocols at each body part that we get to as far as the different body systems go. But they're all back here in the back of the book. She goes from head through temporal bones to orbits, to all of those are back there. So you can kind of look over those. The next 3 slides begin a discussion of CT brain anatomy. The next three slides just touch on the most recognizable anatomy. And the slides following these 3 will be more detailed, but they're included in your textbook. So starting on slide 20 here, we have on the anterior section of the image is the frontal sinus, right up here. It's located within the frontal bone, which is up here. Posterior to that is the falx cerebri, which runs right through here. That's the largest fold or septa of the dura mater. Kind of folds itself onto itself within this cavern here. And most posterior is the cerebellum portion down here of the brain. The image on this slide is enhanced with contrast, and you can see the vessels from the circle of Willis here in the middle that are showing up enhanced with contrast. At the anterior portion is the right frontal lobe. Posterior to that is the right temporal lobe, and then the pons is the midbrain. Posterior to the pons is the quadrigeminal cistern, and again at the posterior portion of the brain is the cerebellum. The images on this slide demonstrate 2 separate slices through the mid to upper portion of the brain. The image on the left displays anteriorly the lateral ventricles, and separating the 2 ventricles is the septum pellucidum. Posterior to that, we're able to see the 3rd ventricle coming in, and forming the wall of the 3rd ventricle is the thalamus on both sides. Most posteriorly, we see that ambient cistern coming in. And the image on the right again displays the frontal lobe, the temporal lobe, the choroid plexus, where CSF is produced, and these happen to have calcifications within them, which is a normal variant. Below this is the corpus callosum, and finally the occipital lobe. The following slides contain the CT brain anatomy that's found in your textbook. I've pulled out these 4 or 5, I'm not sure how many there are, but I've pulled these out as pretty much the most important that you might need to know. But I do encourage you to go back and just learn all of this brain anatomy, because they may ask you anything on the registry. So as you go through this anatomy, if you don't understand something, just let me know, contact me, and we'll work through it. So I'm going to play through these slides in just a second, and so you'll know which ones to look at. But just to recap this lecture, in the Romans text, there are key concepts that she's placed throughout the chapter, but we've only scratched the surface of neurological imaging procedures chapter, but we'll discuss most of it in patient care and pharmacology, of course. The first key concept of this lecture is that recent practice favors programming slices of the brain parallel to the supraorbitomeatal line rather than the orbitomeatal line, and this reduces radiation exposure to the lens of the eye. And the next key concept for this lecture is that because of the dense bone of the skull posteriorly or inferiorly, beam hardening artifact is common in that posterior fossa. So it's overcome with thinner slices, currently I think common practice is 5 millimeter slices through the entire brain. Some places may still do 5 millimeter and then 10 millimeter slices. But I think for the accepted practice today is 5 millimeters. So that concludes our brain, non-contrast brain lecture. I'm just going to play through these slides. You can kind of pick up which ones that you need to get out of the book and get into and really study and learn. I'll talk to you next time.